It's my pleasure to welcome you in our fourth webinar. This is the fourth out of 8 webinars, so we are halfway through. This time, I would like to shed some light on VWIN Foundation, Venous Lymphatic World International Network, with its 3 stars, Professor Sergio Genesini, Professor Oscar Bottini, Professor Willie Kai. Actually, VWIN Foundation played a key role in the creation of this educational event, which joins the 2 continents of Latin America and Africa through the passion of treatment of venous diseases. I would like to take this opportunity to thank all the professionals in both continents and actually in every corner of the world who dedicated their time and expertise to participate and enrich this event. Today's theme is about ultrasound. Well, ultrasound, as we all know, is at the heart of the venous system, the diagnosis and therapeutic. The speakers are Professor Sriram Narayanan and Professor Paul Gagné. Both are very well-known experts in their field. It's my pleasure to introduce our esteemed panelists. They will be introduced in person later in the session. It's also, I'm delighted to have with us our guest of honor from Egypt, Professor Ahmed Hussein, and our guest of honor from Latin America, Professor Alfredo Prego of Uruguay, who are going to present it later in the session. I would like to remind you of our award, $500 in flight stipend, plus free registration to the VWinter conference, which will be held in Dubai in January 2022. And we have a member of 10 internationally known figures, which will decide which is the winning question. Finally, I would like to thank our sponsors, our main sponsor, Servier Daflon, our gold sponsor, Petronic, and our sponsors, Biolytic, ECS, and Medi, without whom this would have been impossible. I would like to remind you that there is instant translation from English to Spanish. And finally, I would like to leave the word to Professor Sriram Narayanan. I'm sorry about not pronouncing his name correctly. He's a busy vascular surgeon. He's director of the Vascular Center at Harley Street, Singapore. He's the elected General Secretary of the Asian Venous Forum, among many other important commitments. Please, Dr. Sriram.
Thank you very much, Rashad. I'm going to share my screen now. Let me try. Well, thank you all again, and thank you, Rashad, and thank you, Sergio, Oscar, and Willie for having organized this. It's an absolute pleasure to be here amongst friends again. And when Rashad sent me this topic and asked me if I wanted to change the title of the topic, I said no, because it was such an interesting topic. And the reason for that is that pretty much all of you who are phlebologists and practicing vein surgery will have some idea of ultrasound, either how to interpret it, and I'm sure most of you do it yourself. So rather than do a presentation and a talk on the standard approach to ultrasound, what is reflux, 500 milliseconds, and all of the normal stuff that I'm sure that you already do, and this is not really an ultrasound workshop, I thought I would build up to a set of golden rules by presenting both our approach to ultrasound and then a couple of cases towards the end. So let us understand what are the goals of scanning. And it seems quite a simple question, but it can be a lot more than just, I'm trying to get this off so that I can read the slide. It can be a lot more than just diagnosis or planning and intervention. If you want to make a diagnosis, ideally your scanning should be comprehensive, whether you're looking for obstruction and incompetence, and whether you're looking for that in the deep and the superficial system. Then, of course, there's the question of time in a busy practice. There's the cost of equipment, what facility you have. Do you have a vascular sonographer? Do you do it yourself? Do you have a vascular technician? And then there are skill constraints on that. Then there's the issue of emergency scanning. Are you scanning in the middle of the night? In which case you can't do a detailed scan for various anatomical segments that might be incompetent. You may just be looking for, is there thrombosis or is there bleeding, so that you can start some intervention. Then are you scanning because you're following up a patient on whom you've done an intervention? Are you looking for a specific postoperative change like inflammation after glue? Are you looking to see if there's recanalization of a procedure you've done? And then the procedural scans, which are ultrasound scans you do under ultrasound guided procedures in the operating theater, there the equipment may have limitations, because a very large ultrasound machine in a diagnostic lab may not be the same in terms of software and capability to what you may have in the operating theater, especially if you've got a portable system with no pulse wave Doppler. That is the reason why I'm doing a particular scan, because no patient is going to have all possible scanning done. And there are 5 basic components when you do an ultrasound scan for venous disease. You're firstly trying to find out what anatomy is like, and there are many variations. You are trying to assess compressibility. This is, of course, in the suspected obstructed situation. So you're looking for distended and non-distended and vessels, whether they compress, and what is the echogenicity of what is not compressing. You're then, of course, assessing along the anatomy various refluxing segments and whether certain junctions are involved. Then you have to assess the augmentation to flow, and I will come in some detail to that, especially phasicity, which is it respiratory or cardiac, and what is the response to your various provocation maneuvers, whether it's Valsalva, whether it's compression of the calf, whether it's a foot tap, or you use something like a Venopulse. And then, of course, you must try to localize the cause. Is it an NIVL causing the disease? Is it a vascular malformation? Are there pelvic escape veins? So all these components are things you need to think about when you plan your scan. And these 3 pictures will show you about compressibility and reflux as well. I'll just move this down 1 second. Reflux as well as phasicity. So in this case, you can see this is a compressible vessel, and you can see in the second slide that it's a non-compressible vessel. The duration of the reflux can be assessed in terms of incompetence from the spectral waveform or the pulse wave Doppler, and you really have to learn to look at that every time. And then above and below, you see 2 phasic responses on the right-hand side. This essentially is 12, 14, 16 times a minute kind of phasicity. That is respiratory phasicity, which is fairly normal. But if you see, look at it below, this is probably a 60 to 80 times a minute kind of phasicity. This is really a reflection of the cardiac pulse, and you're probably looking at a patient with right heart failure. So looking at the nature of phasicity and actually counting it will tell you, is it just normal respiratory phasicity, or are you actually looking at a patient who might need his cardiac status corrected before you try and do a varicose vein intervention? Of course, there is the problem of position. As you can see on the picture on the right, there's this guy hanging in free fall, and our physiology in the cardiovascular system changes with various positions, be it the heart rate, be it the venous return, be it the arterial venous reflex in the leg. All these change with position. And it's important to understand that depending on what you're looking for, the position of the patient will have to change. So for example, if you're looking at incompetence, you might be looking at a patient either with a standing table like this. It has to be done in the standing position. On the other hand, if you're looking at obstructive disease, then it has to be done with the patient lying down. So if you're trying to do one scan where you're looking for everything, you're going to have to have the patient stand first, lie down later, or lie down first and stand later, and it all becomes a bit complicated. So you have, am I doing a targeted scan either for incompetence or for obstructive disease or in an emergency scenario? Or do I have the luxury of a tilt table system that allows me to do both at the same time? We prefer to do our scanning using a tilt table system so that if we are doing targeted scanning, we can either do it lying down or with the patient standing up. Or if we are doing a full-blown scan, then we can do both without having the patient stand up and sit down and move around. So you must have a protocol, you must have a plan. And it's nice to have templates that you create for yourself. Various labs have various templates. It's important you have your own template. And the templates need to be separate for incompetence and thrombosis. Remember, incompetence, you will be scanning with the patient standing, and the way you map the patient is a bit different from what you're looking for in a patient with thrombosis. You must plan your position changes as well, so that if you think that an incompetence may be due to a venous outflow obstruction, then you must be prepared to do the patient scan both in the standing as well as the lying down position. And this is a nice line to remember in ultrasound scanning, which is you need to track the vein that is incompetent right down to the level of competence. And sometimes you might not find it because it's incompetent right down to the ankle. And when you're looking for thrombosis, you have to track the ultrasound scan right up to the point where you finally find a patent truncal vessel. So track down to incompetence and track up to a patent vein. It is important to communicate the problem. And I think this is a big issue in patients, in places where you have these large specialty hospitals where somebody does the ultrasound scan and all you have is a report and a few still pictures in front of you. Ultrasound is really dynamic. So let me give you an example. If you see this ultrasound picture, is my cursor showing? If you see this ultrasound picture, I'll put the laser pointer on, give me a second. Okay. If you see this ultrasound picture, this is an ultrasound picture of an acute DVT of this patient on the left. But here, just here, you can see 1 centimeter from the saphenofemoral junction, you can see this echogenic line in between. This is a free-floating thrombus in the femoral vein. If you're going to try to ensure that this is a thrombus and keep pressing the compressor, assessing the compressibility by pressing too hard, you will be taking the thrombus out of the pulmonary artery. So do not press too hard. It is important, therefore, that when you are communicating with the person scanning, you need to let them know this is an acute DVT. The patient has had some respiratory symptoms. Please go gentle on the compression. On the other hand, if you suspect that there might be a vascular malformation, you need to communicate that, because then they need to do and switch to a musculoskeletal mode if required. If you're using a tilt table, it is important to let them know that this is an acute DVT, because if the patient has a PE and you do tilt table testing on them, and then you might have a cardiorespiratory compromise. So your eyes won't see what your mind doesn't know. You must familiarize yourself nowadays with the appearance of post-operative changes. This here is the appearance of post-operative glue in a patient who then presented thinking she had a recurrence, which she really didn't. And this is what glue looks like inside the saphenous vein dipping into a perforator vein just near the malleolus. So you must familiarize yourself, and the best way to do it is to scan your patients after procedures repeatedly. You must also learn the other appearance, which is of a thermally ablated vein. So whether you do thermal or non-thermal ablation, you need to learn the appearance of these. This patient on the left was done by many years ago, over 12 years ago, by one of our good friends, Kursat, in Istanbul. And then she developed a recurrence some years later and was operated at the Emory Vein Center in the US. And then she recurred again, and I will talk a bit more about her. The ultrasound Doppler on the right-hand side with spectral wave is really the recurrent anterior accessory vein. The other thing to remember is that the spectral Doppler waveform is important. Too many people just look at the color Doppler picture to try and diagnose reflux. That is not as accurate as a pulse wave Doppler in actually quantifying the degree of reflux you have. Unless, of course, you want to just see some reflux so that you can do a procedure. That, of course, is not something we should be doing. You must quantify the reflux on the spectral velocity. And you must confirm that if this is the augmentation signal, this is the retrograde flow, and that the spectral Doppler shows that you're truly having retrograde reflux. Spectral Doppler also allows you to see slow flow reflux. Now, this is a patient in whom you get this slow flow, and again here you get this slow flow, and you can adjust the sensitivity of the pulse wave Doppler to be able to diagnose these. If you're not looking at the spectral waveform and only looking at the color Doppler, then you will miss these incompetent segments. So it is important that you make it a habit to use pulse wave Doppler or spectral Doppler when you are doing your ultrasound scanning. The other thing that pulse wave will detect is delayed reflux. So if you look at this patient, the augmentation's been done on the left, and then there's a gap. And then you think there's no reflux, and then slowly the reflux appears from the gluteal escape vein. And the same thing is again seen on the right side in the GSV of the same patient. It was the gluteal escape that was filling the GSV in a patient who had pelvic congestion syndrome. So it is important that you learn to play with the spectral Doppler so that you can both diagnose slow flow as well as delayed reflux in these patients. Of course, it is extremely important to search for a source. I've just shown you this picture on the left. This patient had a short saphenous filling because of a pelvic escape in a patient with pelvic congestion syndrome. This patient essentially had this kind of Doppler picture because there was a left-sided non-thrombotic iliac vein lesion causing an 80% reduction on ultrasound. We, of course, went on to do the IVUS before we treated this patient. You might have noticed in the previous slide this term veno-arteriolar flow index, which is on the right 1.43 and on the left 0.69, the normal being 1 and 1.2. Let me explain that a bit. The veno-arterial flow index is fairly easy to understand. Logically, if you have 1 liter of blood going down the femoral artery in a minute, you should have 1 liter of blood coming out of the femoral vein in a minute. If less than a liter is coming out of the femoral vein, there's likely to be an obstruction to the outflow. But if 1 liter is going in and 2 liters are coming out, that seems a bit odd. But basically that patient has an incompetence, and because it is measured over a period of 15 seconds and then converted to 1 minute, you're essentially seeing the same blood going up and down the venous column. So you can see here that this patient has got a low VAFI on the left and a normal VAFI on the right. And this patient came in with right-sided varicose veins, but on further history, she had post-coital ache and a history of pelvic congestion syndrome, but she had never actually linked the two. So then if you go on with this patient, you do a venography and you see the huge pelvic collaterals coming out when you do a venography from the left side. And the patient, of course, under IVUS guidance, then required stenting in order to ensure that her PCS symptoms settled. And at the same time, we went ahead and did a right GSV RFA. So she presented with right-sided GSV incompetence because of a left-sided non-thrombotic iliac vein lesion that was leading to PCS with cross-pelvic collaterals feeding that GSV. So it is important you track on ultrasound the source and possible outflow obstruction that might be at the top. I'm sure Paul will speak much more and more eloquently about the IVUS to come. When we talk about this again is Kursad's patient. I will bring this patient back. It's not, of course, Kursad's fault. There was no IVUS when he did these patients, and we didn't really know about an IVL in those days. But this patient had 2 recurrences, and again, the veno-arterial flow indices are extremely low on the left. But we could see that there was a positive for left non-thrombotic iliac vein lesion. So this is the patient's IVUS, but if you actually see, that's the normal left common iliac vein. with a significant NIVL on the left. The patient then, of course, went on to have this side ablated, which is just the anterior axillary saphenous vein, and also went on to have left iliac vein stenting because of the recurrence. So when you search for the recurrence, if you actually see this patient, you do a transanterior axillary saphenous venogram, and this is what you see. This is through the anterior axillary saphenous vein. You can see a bit of the segment of the great saphenous vein and the femoral. But when you do the same thing on the Valsalva, this is what you get. This is a pelvic escape vein causing filling of the anterior axillary vein. So if you do not address this primarily, then you are going to have recurrent episodes of reflux. I will then move on very quickly to this patient. You can't obviously see the NIVL, but when we move down into the next slide, I will show you that an NIVL does not only have to be an arterial compression. If you see this vein here, this is the external iliac vein. It is so thickened, and this is an iliac endofibrosis secondary to the fact that she was a competitive cyclist in her 20s and 30s. So if we play the video of this, you will see that during Valsalva, the external iliac vein hardly expands. I've seen this 3 times now, and it was presented at Charing Cross that there is also iliac venous endofibrosis in rowers and competitive cyclists. So this had led to the high pressure system feeding the pelvic escape veins, and therefore leading to the fact that she had an anterior accessory incompetence. That then builds up nicely to the golden rules that I would like to present, which is you must know the reasons for why you are scanning. Are you looking for incompetence or obstruction? Are you scanning in an emergency? Do you just have a swollen leg and that you're making a diagnostic scan to try and figure out what may be the cause of that swollen leg? And are you dealing with a recurrence? You must communicate these suspicions to whoever is scanning. If you're scanning yourself, that's great. But if you have somebody else scanning for you, then you must communicate this after you've done your clinical assessment. You must scan in the right position and with the right equipment. To do diagnostic scanning without spectral Doppler being available is probably not perfect. You must also be able to scan the patient both in the lying down and in the standing position, depending on what you're looking for. Be careful when you compress, you can detach thrombi. So compress with care, but watch your spectral Doppler over time. Don't just stop it immediately because slow flow and delayed reflux do occur. And always look for a source. The proximal end of the source, the distal end of the competence, whether it's from the deep or from extra anatomical veins. And build yourself a plan, follow a protocol, and have a template. These are my golden rules for ultrasound scanning. It would be a delight if we are actually able to conduct this symposium next year, which we had to cancel this year, but I would love to welcome you all to Singapore from the 7th to 10th of July next year, if COVID allows us to do so. Thank you very much.
Thank you, Dr. Sriram. Excellent presentation. And if we take in consideration that it's now half an hour after midnight in Singapore, and that you spent the last couple of nights with ruptured aortic aneurysm, that's really fantastic. Thank you. We are late, as we have always been. So I'm going to ask you to be concise with your answers, please.
Sure.
Dr. Please present the panelists.
Yes.
Dr. Wasila, are you with us?
Yes, but Dr. Sriram, he should stop sharing his screen.
I'm not sharing my screen anymore.
All right. Could you see my screen now?
Yes.
Yeah.
Yes, okay. Welcome to our fourth night, Saturday night vein talk. Excellent presentation, Sriram, as usual. I'm honored to introduce our panelists for this night. The first panelist is Professor Mathieu Josselin. consultant of vascular medicine and geologist from France, La Roche-sur-Yon, and president of the French Society of Phlebology. He recently elected just last July, and this society is really a leader one, a great one with large number of members and significant impact on phlebology research, at least 2 RCT per year, and with continuous educational training. Congratulations, Mathieu, for such a new post, and good luck for your post. And now the podium is yours to address your question for Dr. Sriram. Please, Mathieu.
Okay, thank you, Wasila. I would like to thank Dr. Rashad Bishraba for your invitation, kind invitation. Thanks to Dr. Ganeshini, Dr. Bottini, and Dr. Witt. And I am vascular physician, as you say, in France, and current president of the French Society of Phlebology, and it's a very big honor to be a part of this discussion tonight. Thank you, Dr. Nara Nayan, for your very good presentation. For me, it's a very good global vision of the venous ultrasound, and it could be very useful for the French students, I think. I am passionate about the background, but also about teaching around the world. And my question is not very technical. Is in your opinion, how long does it take for a medical student to be trained in ultrasound, to have the skills you described? How many exams you have to do to get this expertise in this field?
I think the key thing is to know the anatomy and to know the disease. Your speed of learning will depend on how much you know about the disease. Like I said, the eyes won't see what the mind doesn't know. So someone who's already learned the medicine will learn to scan much quicker, probably 6 months to a year, they will be competent. But if you're going to learn the anatomy, the disease of phlebology, as well as ultrasound at the same time, then it might take a little longer than that.
Okay, thank you. It's very interesting. In France, we have not very big teaching in this field. It's a companionship. There is very short study, and we have to learn on when we practice in phlebology, not in all the vascular medicine. So it's very difficult to have a good teaching in France, but its companionship is very important for us. Thank you.
Thank you.
And now truly honored to introduce someone who really does not need any introduction, Professor Najib Bouayed. Professor Bouayed from Algeria is a big icon of vascular surgery in Algeria and all the region, North Africa. He's professor of vascular surgery in Oran University, member of the French National Academy of Surgery, president of the Algerian Association of Vascular Surgery, chairman of the Certificate of Specialization in Vascular Duplex Ultrasound or L'Echodoppler. Najib, the podium is yours now.
Thank you, Wathila. Thank you, Rashad, for this great webinar. And congratulations for Dr. Narayanan.
This RAM is fine. It's easier as RAM.
Yes.
RAM.
Very nice presentation.
Thank you.
It was very interesting. And I have a question for you. In women who have varicose veins, you systematically seek perineal venous reflex, knowing that recurrences are often linked in this persistent perineal reflex in women who have had prognosis. These reflex points are sometimes difficult to highlight when they should be precisely located to have a good, safe treatment. What is your opinion?
Could I quickly ask you to repeat that? I didn't get all of that question.
I don't listen you. What?
Yeah, could you quickly repeat that question? I didn't understand all of it.
About the perineal reflex in women, systematically seek and search this perineal reflex.
Oh, perineal reflux.
Yeah.
Yes. No. We don't systematically seek it. If we are looking at incompetence, we do a veno-arterial index, flow index of VAFI at the groin. If the groin is low, then you will be able to find if there is a pelvic escape. On the other hand, if the VAFI is not low, it is pointless going around looking for a pelvic escape because there is no outflow obstruction. What you are looking for is a communication between the pelvis and the lower limb. And if the Wafi is normal, then we don't bother.
Even in a woman who have had a lot of pregnancies?
We don't systematically go looking for it, but if there is a leak from the pelvis into the limb, then you will see it in terms of the changes in the veno-arterial flow. But we do scan every patient, even in incompetence, not just to the inguinal ligament, but we do scan them because we have a tilt table, we lie them down, and we look higher up as well into the iliac system, yes.
Okay, thank you very much. Thank you.
Professor Genesini, could you please introduce Juan Chunga?
Yes, it will be my pleasure. I could do that in many different ways as like one of the experts in the world about sclerotherapy, as a leading figure of the Peruvian Society, but I will go with the friend of many of us, Juan. Juan?
Juan, could you please ask your question?
Okay. Hi. I want to thank the organizing committee for considering me for this night. It is my privilege. Dr. Siriam, it's always a pleasure to hear you talk about ultrasound or IVUS since I met you. My question is, do you think that there is still debate between the clinical response of the patient and the occlusion that we seen by ultrasound? If so, what is your position and or recommendation if a patient comes to a control whose clinical improvement is excellent, but upon mapping, we find that the vein has not completely occluded or there is still a reflux?
Okay, very good question, Juan. Thank you. We must understand that we are not treating pictures, we are treating patients. Our definition of an ultrasound reflux is an arbitrary definition, which is essentially that there has been flow across a valve or a valvular segment that lasts a particular amount of time, 500 milliseconds. That does not mean someone who has 499 milliseconds of reflux is better than someone who has 501 milliseconds of reflux. So really you have to go by the symptoms, regardless of what you might see on the ultrasound. If symptomatically or cosmetically, if it's a cosmetic issue, you do not see that there is a significant clinical problem, then what you see on the ultrasound, it really doesn't matter. In fact, one has to ask the question, if they're not symptomatic and not cosmetically seen, why were you doing the ultrasound in the first place?
Thank you. Now it's my pleasure to introduce Dr. Lorena Gringo. She's professor of vascular surgery at San Jose, Costa Rica, and she's also president of Flevo-LATAM, among many other commitments. Professor Lorena, could you please go ahead and pick up one or two questions from the Q&A box? Thank you.
Yes. From the Q&A box, we have several nice questions and very interesting. One from Nihat Fuad. Is there any solid duplex finding confirming that the free-floating thrombus has been fixed?
The answer is no, there is no solid duplex finding. If you see a free-floating thrombus, you must respond to it as if it is going to embolize imminently. So as far as we are concerned, the anticoagulation begins, the bed rest begins, and if you're planning to take the thrombus out, then you need to do that. When we deal with a known free-floating thrombus, we would usually cover the IVC from the opposite side. We used to use filters in the past, but nowadays we use a Capture-X device, which is like a funnel which is able to catch the system so that we can take it out at the end of the procedure. So there is no solid duplex finding, but if you see it, then your response has to be fairly quick.
We also have another question from Dr. Mohammed Ramadan. How much reliable is the veno-arterial index, and is it enough to diagnose venous pathology?
Right. We have now done just over 300, and we're about to publish this data, and it is extremely reliable. It initially began from Lübeck in Germany, where a high veno-arterial flow index was diagnostic of reflux. But we began to notice as we started doing VAFI that a VAFI of less than 0.7 and you go ahead and do an IVUS in these patients, it is pretty much 100% diagnostic of an outflow obstruction. So that does not mean 0.8 or 0.9 is not, but below 0.7, it is almost 100% diagnostic that you have a significant NIVL. Does that mean you should treat everybody who has an NIVL? That's a different story. But you do find a lesion on IVUS at less than 0.7 of an outflow obstruction, yes. That will be published fairly soon now.
Very interesting.
Thank you, Lorena, for picking a couple of good questions. We have to move on for the sake of time. And now Dr. Wasila have a little surprise for us. Dr. Wasila, please.
Here is the surprise. We celebrate today the birthday of Dr. Erika Menegatti. Dr. Menegatti, she is a PhD holder, researcher of venous physics and hemodynamics at Ferrara University and board member of the VWIN Foundation. Actually, she is the treasurer. Bon compleanno, Erika. Have a blessed year ahead.
Khaled, can you give the mic to Erika, please, or is this not possible? Can you unmute Erika? Okay, well, we'll move on.
Yes,
Can
Dr.
you hear me?
Yes, please.
Can you hear me?
Yes, Erika, absolutely.
Thank you very much. This surprise is the best of the day. So thank you very much for these kind wishes. Thank you.
Happy birthday, beautiful Erika.
Thank you very much. Ciao, ciao.
And now it's my pleasure to introduce our second speaker, Professor Paul Gagné. Professor Paul Gagné is Associate Professor at New York University. He's Director of the Vascular Research Laboratory, and he's the Principal Global Investigator of the famous video study. He's going to talk to us about IVUS. Professor Gagné, please go ahead. Share your screen.
I will share my screen. And you can see my presentation.
Yes, Paul, we can see you.
Okay, thank you. So I'd like to thank the organizers, Dr. Bashir and Dr. Wasili and Sergio for the invitation to participate in this pretty exciting meeting. It's a real honor. My goal is to talk to you about IVUS and that it's an important tool in deep venous interventions. These are my disclosures. So we all have these patients with advanced venous disease, these SEAT 4, 5, and 6 patients with skin damage, stasis dermatitis, swelling, heaviness, and ulceration. And then we have some of these patients that have small ulcers, which over time, in spite of best conservative measures, advance to these terrible wounds. We know from the report by Marston and colleagues in 2011 that if you look at patients who have SEAT 5 and 6 disease, so patients who have or have had ulcers, that when you look at their iliac veins with axial imaging, 37% of these patients will have a greater than 50% iliac vein stenosis, and 23% will have a greater than 80% iliac vein stenosis, showing that iliac vein outflow obstruction is an important component in their overall chronic venous hypertension and clinical presentation. We also know from a report in 1968 from Negus that venography for iliac and common femoral vein outflow obstruction has poor diagnostic sensitivity. And in more recent studies from Raju and colleagues, that 34% of patients with chronic venous symptoms have an iliac vein obstruction in a normal venogram if you use IVUS as the gold standard, and that only 43% of patients with significant outflow obstruction will have collaterals. So collaterals are very specific when you see them, but they're not very sensitive. One of the problems with fluoroscopy and venography is that veins often exist as an ellipse, as seen here, especially at a compression lesion. And so when you do an AP view on venography, it may look like the vein is of normal size. It is only when you find the proper angle to evaluate the vein that you see the severity of the stenosis. The question is, how many views do you have to do how much radiation do you have to use, and how much contrast do you need to do to find these lesions. It can be quite challenging. And you can't fix what you can't see. And we know that all the endovascular interventions we now have possible, such as aortic stent grafts, carotid stents, lower extremity arterial interventions, are possible due to advanced and available vascular imaging. IVUS is particularly helpful for diagnosing outflow obstruction in the iliac and common femoral veins, and also is very helpful in assisting with stenting when appropriate. As Ram commented on, you can find these focal compression lesions, but you also see post-thrombotic diffuse disease, and I'll show you some examples in a minute. You also get information about phasic changes within the inferior vena cava. If you find that the vena cava is distended without phasic changes, then you have a pretty clear understanding that this patient has fluid overload and probably some right heart failure or elevated pressures. It's also helpful when you're stenting to identify the reference vessel size. And because IVUS as an ultrasound technology is dynamic imaging, you will see phasic changes within the iliac veins. So that veins can change in size with breathing up to 30%. And this is important to take into account when you're sizing a stent. And then finally, you identify the junction of the deep femoral vein and femoral vein, or the external and internal iliac vein, very easily with intravascular ultrasound, which is important when you're planning your stent. So here's a high-grade compression lesion here, identified with intravascular ultrasound compared to the reference vessel in this patient who had a small ulcer that became quite large and out of control. 9 months later, after stenting, we've now progressed to near healing. This patient went on to heal and had no recurrences over the next 5 years. These are the types of lesions you can find with intravascular ultrasound. Here's a normal vein. You see it is generally bigger than the adjacent artery, as we see here, the vein. And here you see a small contracted vein. It'll be patent on venogram, but it's not much bigger than the artery. And you see this web going right through the center of the vein, which won't necessarily be well depicted on venography. Again, the vein is small, adjacent to the artery. You see the scar in the vein. These are findings that you identify with IVUS that you will not see well with contrast-based imaging. And finally, you see this very small web in a patient who had clinical SEAT4 disease seen with IVUS, and it's really uncertain whether that's actually a true fixed lesion. But then when you blow up a balloon, and I will say it was actually tighter before I took my foot off the pedal, this was a high-grade stenosis, and when you stent these lesions, the patients clinically improve. Now, not everybody was ready to agree that IVUS was the best imaging at one point, so we performed the video study to evaluate multiplanar venography versus intravascular ultrasound for diagnosing outflow obstruction and guiding treatment of stent obstruction, of vein obstruction. This was a prospective multi-center study performed at 14 sites around the world. 100 patients with SEAT4, 5, and 6 disease were prospectively entered into the study. We performed multiplanar venography with 3 views. We recorded if there was a stenosis, where the stenosis was, how severe the stenosis was, and how it was going to be treated. Once that had been recorded, we then did the same with intravascular ultrasound. We identified the stenosis, the location, the severity, and how it would be treated. All patients were followed up at 6 months. We had standardization on the venograms. An injection was performed from the femoral vein with contrast, and 3 views, AP, 30 degrees RAO, and LAO were recorded for the venograms, and a significant stenosis was considered to be a venogram diameter reduction of 50% or an IVUS cross-sectional area reduction of 50%. What they found in the 300 vein segments, common iliac, external iliac, and common femoral veins, was that we had a high-grade stenosis with intravascular ultrasound not seen with venogram in 21% of the vein segments, so 1/5 of the vein segments. And it was very rare that we would have a stenosis seen with venogram that was not detected with intravascular ultrasound. So IVUS is much more sensitive for detecting an outflow obstruction than multiplanar venography. More importantly, the information gained from IVUS changed the treatment decisions in 60% of the patients. And in 50 patients, or half of the patients in the study, the number of stents that were used to treat these patients changed based on IVUS from 0 to 1 or 1 to 2 compared to venography. So without IVUS, you end up undertreating iliac and common femoral vein outflow obstruction. So intravascular ultrasound is really the best, most sensitive imaging for identifying iliac and common femoral vein disease in seat 4, 5, and 6 patients based on the video study, and is the best guide for stent intervention. When you look at the IVUS guided stenting in the video study, those patients at 30 days had a significant improvement in their venous clinical severity score of greater than or equal to 4. And this benefit to the patients continued out to 6 months, suggesting that IVUS was sensitive for detecting these lesions and translating that into clinical improvement. When you compare that to multiplanar venography, as we see here, a 50% stenosis on multiplanar venography in this receiver operating curve analysis did not predict clinical improvement when stented at 6 months. But whether you looked at IVUS diameter stenosis or IVUS area stenosis greater than 50%, if you stented these patients, you could predict at 6 months that those patients would get better. And this was statistically meaningful. So in conclusion, a 50% baseline stenosis measured with intravascular ultrasound when treated with a stent predicts clinical improvement at 6 months, whereas multiplanar venogram detected 50% diameter stenosis when treated has no clinical predictability for improvement at 6 months. Now, these lessons learned in video, have they been repeated? Well, if IVUS best identifies these stenosis, does treatment seem to help patients? The video study would suggest stenting does. When we look at this report from Raju and colleagues in 2006, they looked at compression lesions in 332 limbs, and when IVUS-guided stenting was performed, 80% of the patients had relief of pain, 3/4 of the patients healed their ulcers, and over half the patients had improvement in swelling. So they concluded that in seat 3 through 6 patients, compression lesions were common and that stent placement was significant for providing relief. When we look at this more recent study by Rossi and colleagues, they performed intravascular ultrasound on a group of patients who had been treated with compression and wound care for a period of time who had seat 3 through 6 disease. In those patients who were identified with IVUS to have a 50% or greater stenosis, they randomized those patients to continued compression and wound care, or wound care, compression, and IVUS-guided stenting. And what they found is in follow-up that the pain scores, the VCSS scores, and the quality of life scores all improved in a statistically meaningful way compared to compression and wound care alone. And even in the patients who had ulcers, you see a significant improvement in ulcer healing. And although this didn't quite reach statistical significance, it was a small number of patients, only about 15, and therefore this may represent a type 2 error. So IVUS-guided deep vein stenting is safe and effective and has rapid relief of chronic venous hypertension symptoms and improves the quality of life in these patients. So in conclusion, IVUS is really an essential imaging modality to diagnose iliofemoral vein occlusive disease. It guides safe stenting. IVUS-guided stents improve the quality of life of patients with seat 4, 5, and 6 disease. And if you evaluate patients with advanced chronic venous disease without using IVUS, you will misdiagnose patients and provide substandard care. Thank you.
Thank you, Dr. Paul Gagné, for this excellent presentation, and thank you for keeping on time. And now, Dr. Wasila, would you like to present the panelists, please?
Yes, Dr. Rashad. We have the honor, are truly honored having Professor Xin Liu from Malaysia among us this night. He's consultant of vascular surgery at Sim Darby Medical Center, professor of surgery in University Putra, and the past president of Vascular Society of Malaysia, chairman of the Asian Symposium 2017, the chair of Venous Thrombosis Prevention Forum since 2010, and he's the principal author for the Asian Recent Guidelines 2013 and updated 2017. Professor Bui, the podium is yours now.
Thank you, Wasila. I'm sure you can hear me.
Yes, perfectly.
Thank you. Yeah, Paul, it's an excellent lecture. I've heard you over the years now. Now, in the past, I always thought that IVUS is useful as an ancillary tool when we want to stent the iliac lesions. But it seems that science has progressed rapidly now. And I think it is also a very useful tool when we manage C4 to C6 lesions. Now, for those of us who do not get access to IVUS so readily, where will you position IVUS? Let's say when a person comes in with a venous ulcer, do you start off with, say, either duplex scan, and then go on CT venography or MR venography, and then invasive venogram, or some hemodynamic studies? Now, where will you position IVUS here?
So we're fortunate to have IVUS available. But that being said, a patient who presents with a venous ulcer, we first do a comprehensive study, as Ram described a short while ago. And then based on what we find and the severity of the ulcer, we then make a decision about whether to evaluate the deep veins with IVUS. So what I mean by that is, if you have a focal ulcer in the bed of one of the superficial axial veins or a perforator vein, we may go ahead and treat that first. But once we see the larger venous ulcers with skin changes that are wrapping around the leg, so it's not focal, say on the medial malleolus, but wrapping around the leg, those are the patients that we tend to believe have outflow obstruction. And those are the patients we would proceed to intravascular ultrasound. You know, if you see a lesion on CAT scan, it's very specific as far as outflow obstruction. The problem is you may not see a lesion, and there are all kinds of intraluminal scars that can be present that you may not see on axial imaging. So I feel even if you don't find something on CAT scan, if you have that wraparound skin damage, you kind of need to do intravascular ultrasound.
Dr. Wasila, please.
Yes, Dr. Rashad. Now we are delighted to introduce Dr. Ahmed Khairi Allam from Egypt. He is Associate Professor of Vascular Surgery, Banha University, Associate Member of IVLA, and Dr. Allam is ranked #1 Egyptian Fellowship for Vascular and Endovascular Surgery last year, 2019, for which he has been awarded the grant of the late Professor Ahmed Sabeddin. Dr. Allam, the podium is yours now.
Many thanks, dear Professor Wasila, for your kind invitation, and Professor Rashad Bishara for attending this great educational event. My question to Prof. Garnier regarding the IVUS. No one can deny the important role of IVUS in venous practice. But in era of dedicated venous stent, are there any solid data confirm superiority of dedicated venous stent versus or over non-dedicated stent supported by IVUS? This is my first question. Second question, in absence of IVUS reimbursement, how can we increase or improve the outcome of conventional venography in diagnosis and treating venous lesion?
Thank you. I had some difficulty hearing the first question, so let me start with the second one, and then maybe you can restate it for me. The question of what can we do with venography to make it better? Unfortunately, other than doing multiple views with the increased radiation and contrast, it's not clear that you can improve the venography. Sometimes there are suspicious areas, like you saw in one of my slides, where even though the diameter of the vein looked normal, the thickness or the depth of the contrast seemed to be diminished, and that may mean there's a compression lesion. One thing that I've done in recent years is I also will inflate a balloon, 14 to 16 millimeter balloon in the veins, and if I see a tight waist, I'm suspicious that there is a lesion there. But at the end of the day, you know, we know that with compression lesions, we oftentimes do not see a severe stenosis or a moderate, we see only maybe a moderate stenosis on the balloon. And until you measure the actual reduction in the cross-sectional area, it's hard to know whether that's critical or not. So I recognize that IVUS is a challenge and not available in many places. I would say that my best advice is to try to find a mechanism to borrow it from your cardiologist or others who might have it accessible to them.
Dr. Gani, the first question is regarding choice of stent based on IVUS. Does IVUS help in the choice of stent?
Thank you. Yes, excellent question. So when I'm using a wall stent, I measure the cross-sectional area of the vein with IVUS. I look for phasic changes with deep breathing. When I see the maximal size, you get a minimum and maximum diameter. I add the two, I divide by 2, and get the average. My stent, if I'm using a wall stent, which has the ability to change size based on the length and the conformity, I usually upsize a minimum of 2 and a maximum of 4 millimeters. With the nitinol stents, though, if you oversize to that degree, you're probably going to cause pain that's unnecessary and maybe some in-stent stenosis. So at that point, I generally like to size the stent 1 to 2 millimeters. And I like to make sure that the stent is sized to the size of the vein, not just at the stenotic lesion, but that it's well anchored in normal vein by a minimum of 1 to 2 millimeters oversizing so that it doesn't embolize.
Very nice, thank you. Dr. Lorena, please.
Yes, one question from Dr. Esat Kinoliev. Do you use phlebography in all your patients? And when phlebography is performed, are patients admitted to the hospital or is it doing it on an outpatient basis?
Excellent question. So for the majority of our patients, we will do outpatient in our office phlebography when we do it. There are some patients who, based on their history or their overall medical condition, that we will bring them to the hospital. But probably 85 to 90% of our patients we do in an office setting. As far as who we do phlebography on, sort of the answer similar to what I had before. It's patients with seat 4, 5, and 6 disease, or patients that have seat 3 disease and may manifest venous claudication symptoms. And those patients are the ones that we will do phlebography on.
And the other question will be like a rephrasing and recollection of the other ones. For the ones who don't have IVUS in our everyday clinical practice, when should we ask for IVUS consult to an expert colleague regarding also the data that you could have to show us about the cost effectiveness support with data?
So we've done cost analysis for evaluating these patients with IVUS. And what we've found, at least with the US system, which I recognize may not be similar to systems for reimbursement around the globe, is that the procedure reimbursement can eat up the cost of IVUS. And what I mean by that is your profit may decrease a bit, but you aren't losing money when you add intravascular ultrasound, because at least in the US, if you add a stent to a procedure, there's increased reimbursement. And that increased reimbursement covers the cost of IVUS as well as the stent. So given that you see more treatable disease with IVUS, you end up, if you screen the patients as I've suggested, we don't see a lot of instances where IVUS is a negative study.
And regarding the other part of the question, in which would be the key points in which you should ask for an IVUS expert consult, which would be like maybe the 2 or scenarios that you would suggest to have this interconsult?
If the patient has true venous claudication and you can't identify a reason with transcutaneous ultrasound, that would be one group. The second group is the patients who have seat 4, 5, and 6 disease, and the skin changes are wrapping around the leg. It's not just a small focal lesion, but it's wrapping around the leg. In that setting, we found a very high incidence of lesions detected with IVUS that are improved by treating.
Thank you very much.
Thank you. Great question.
Thank you very much, Dr. Lorena. We'll just make an exception. Dr. Sriram would like to ask you a key question. Go ahead, Dr. Sriram.
It's more a comment than a question. Paul, thank you for a wonderful presentation. I see this question come around often. Some of us have routine access to IVUS. Many others have limited access to IVUS. So when do you use the cost and the device when you're likely to get the best outcomes from it? I'm hoping that the publication on VAFI will change this because most of us will have an ultrasound. VAFI is fairly easy to do. It takes 5 more minutes on an ultrasound scan. And if you find that you have a low VAFI, you're almost certainly going to get a lesion. My suggestion would be that we wait a bit and we will have an absolute number on which we can base when or not we need to do an IVUS, because you will find the lesion with a 0.7 or below VAFI.
Yeah, I have to say, Ram, I'm very intrigued by what you presented to us this morning, and I'm looking forward to seeing that and trying that in our clinics. So if you want to share that with me in advance, at least the technique, I'd be grateful.
Oh, yes, that's no problem. I'll send it to you in the next few days by mail. We were just waiting to build up enough numbers to do a sensible ROC analysis.
Thank you.
Thank you. Now it's time to conclude the session. It's my great pleasure to introduce my longtime colleague, Dr. Wasila. Dr. Wasila really needs no introduction. Everybody knows her. She's a well-known vascular ultrasound expert. She dedicated her professional life to vascular ultrasound. She taught many generations how to conduct proper, high-quality duplex scan through dozens and dozens of courses and workshops in our country and in other countries. Thanks to her, vascular ultrasound has become part of the training of our young vascular surgeons, which I think had a profound impact in our country. She's member of the Educational Committee of UIP. She's also General Secretary of our foundation, Egypt and Africa Vein and Lymph Foundation, and indeed very active secretary. Dr. Wasila is going to wrap up the session. Please go ahead, Dr. Wasila.
Thank you so much, Dr. Rashad Bishara, for such I cannot find the words. I'm really speechless for this nice introduction. Thank you very much. Excellent presentation, both esteemed and distinguished speakers. Now the first part for the ultrasound, Sriram, he had point for the appropriate tools. We have to get the proper probe for vascular ultrasound examination. He also put highlights on the protocol for the superficial venous system. We have to examine our patients on standing position, and I can see there is no agreement like the agreements of all the guidelines that the vascular ultrasound is the cornerstone and the modality of choice for imaging to interrogate and examine our patient for chronic venous insufficiency. Also, Sriram put a lot on the morphology, extracted information from the duplex. As all we know, the saphenous eye or the Egyptian eye, the JSV, the SSB, and more common, we can confuse with the anterior accessory, which is the main reason or the underlying reason for recurrence. So we have to put a lot of attention for the anterior accessory saphenous vein by the duplex. Also speak for the morphology for the compressibility side. So a normal patent vein should be totally compressible. It means the walls biapted and the very thin walls and smooth lining walls. On the other hand, if we have a post-thrombotic venous segment, it's not totally compressed. There is a remnant, there is synechia, there is echogenic lines, which reflects the old thrombi, and it could be also totally occluded, and at this time it could be retracted. This is for the morphology. Also very highlighted for the hemodynamics impacts of the duplex, and it's not only the reflux duration that counts, it's also the Doppler spectrum analysis. So he had pointed for the example, loss of phasicity. Loss of phasicity, it reflects there is an outflow obstruction or a proximal obstruction. This is very important in the PTS conditions. And also if there is highly pulsatile venous flow, it reflects also a cardiac problem, right-sided heart failure or congestion. And also there is misconception that all the refluxes are the same. In fact, are not the same. We have the axial reflux from the JSB, the SSB, or the anterior accessory saphenous vein, or the other accessories, but also we have the extra-axial varicosities, which is very important in the context of the patients who would like to spare, to whom we would like to spare the JSB, and this is very important. Other important sources of reflux highlighted by Sriram in the non-saphenous varicose veins, which are often combined with the pelvic congestion syndrome. And in this point, he highlighted that it's not only the pelvic varicosities or not only the collaterals or the diameter of the vein itself. He pointed also for the arterial veins index, and we are looking forward, Sriram, for your publication for this point. To complete the deep system for the morphology, also we can analyze the hemodynamic ratios for the non-thrombotic lesions. For the second part by Professor Paul Gagné, excellent presentation as usual, Paul, and congratulations for the VIDEO trial, which highlighted it's a comparative study between the multiplanar venography versus the IVUS. And in this context, we are looking for the patients with advanced clinical manifestations, C4, C5, and C6. And in the VIDEO trial, the IVUS was very sensitive and very accurate to detect the lesions with a threshold of 50% of reduction area, and with versus the multiplanar venography with a statistically significant p-value. And also, he was a very good tool guidance for the stenting for those patients, and also not for the diagnosis only, an important guidance for the stenting procedures, and with a significant improvement of the signs of those patients. And he also, Paul Gagné has also pointed to the publication of Professor Raju. He is very well known for his distinguished work for the iliac vein lesions, the iliac vein stenosis, and using the IVUS. And this literature was for the non-thrombotic lesion. Also, one more time, IVUS was very sensitive and very active to diagnose, and also for the follow-up, up to 2.5 years follow-up. He showed the IVUS that is a significant improvement for the symptoms in terms of the pain relief, in terms of ulcer healing, as well as the relief of the swelling of lower limb. And this is all what I have for the wrap-up. Thank you, Dr. Rashad.
Thank you, Dr. Wasila. And now it's my honor to introduce our guest from Latin America, our honorary chair, Professor Alfredo Prego, who is president of the Society of Uruguay de Flebologia and Lymphologia. Professor Prego, you could speak in English or in Spanish as you wish.
Thank you very much, Dr. Rashad. I will speak in English, and thank you for the organization committee for arranging an excellent scientific session to bridge between Africa and Latin American colleagues. Briefly, we will congrats to both speakers, professor speakers, and in relationship with Dr. Narayan, we strongly agree with the need to have a Venus mapping in addition to the writing report, as we discussed in our LATAM session the last Saturday. In the field of the IVUS, as well, the appearance of Venus dedicated stent was the main step to achieve success in the recanalization of the deep venous system after the iliac DVT, and also the treatment of the non-thrombotic iliac venous lesion. The role of IVUS today is almost essential for a correct assessment of the stenotic area and to get a greater precision during the stent deployment, avoiding, for example, contralateral thrombosis. Unfortunately, and this is my remarks, in Latin America, not majority of our hospitals have this important tool available to work with this, but certainly this is the road to use and to learn IVUS to control the procedures in venous stents. Once again, congratulations for this fabulous session, and just say thank you very much for, and the honor for my participation from the South America.
Thank you. Thank you very much for being with us. We appreciate this. And now it's really my pleasure to introduce my friend and my longtime colleague, Professor Ahmed Hassine, who is our guest of honor from Egypt. Professor Ahmed Hassine had a long history of commitment to the vascular community of Egypt. He was professor and ex-chairman, Department of Vascular Surgery at Ain Shams University. He was the founder and the first president of the Vascular Society of Egypt. He was a founder of the AfroSHAP and of the International Union of Angiology, and he remained vice president of the International Union of Angiology for many years. He's vice president of the Mediterranean Federation for Advancing Vascular Surgery, and he's also founder and program director of Vascular Department at Aswan University, among many other commitments. Professor Ahmed, the screen is yours. You are muted. You are muted. Unmute yourself.
Quite a productive webinar. Thank you so much, Dr. Rashad, for the kind invitation. I would like actually to thank you and thank Dr. Wasila for, and your team, of course, for the hard effort, for just such a great initiative and a noble one as well. I do hope that each of us could really, with his vision and his way of contributing to foster the phlebology practice, education, and training in Egypt and Africa. I would like also to thank the excellent and vivid contribution from Latin America. We have so many friends over there. And that's the proper way of doing things, like joining efforts and joining hands together. Concerning our theme today, just a tiny word to the vascular surgery community and those vascular surgeons among the participants. We had wonderful presentations from Sriram and Paul, and I personally thank them. Quite educational and informative, but for those vascular surgeons among us, especially our junior fellows, no matter how new and sophisticated your machine is, or no matter how expert your ultrasonographer is, please talk to him. Give him the clinical background of the case. You know much more on the clinical background than him, so he has to help you, but you have to help him first in order for him to help you. So that's the way to do proper things, and we integrate, because probably as vascular surgeons we are too busy to give and dedicate our time to the vascular ultrasound, as important as it is, especially the venous ultrasound. And Paul has told us that venography, for instance, is for the venography for the arteries is quite fine, but for the veins we need an extra tool. So again, that was quite fruitful, and I really look forward to, by the way, the panelists were all gorgeous and they were great from different parts of the world, and I thank them very much, and I look forward to seeing you all in our future scientific activities in 2021. Thank you very much.
Thank you, Dr. Ahmed. And with this, we come to the end of our meeting, but there is an important announcement. The Canadian Society is holding a meeting which is running today and tomorrow, and you're all invited, and the link is in the chat box. You find the link is in the chat box. Finally, I would like to thank our sponsors, without whom this would not have been possible. Servier, our gold sponsor, Medtronic, and our support sponsors, Biolitic, ECS, and Medi. Thank you to them, and I would like to remind you that next Saturday is our 5th webinar, and it's going to be about a very exciting topic that's important to all of us, I guess, which is foam sclerotherapy. And I apologize about the 15 minutes delay, but it's Egypt. Good night.
Bye-bye.
Bye-bye.
Thank you.
Thank you.
Thank you.
Bye-bye. Thank you. See you.
Bye-bye.
See you next Saturday. Bye-bye. Bye-bye. Thank you.